Hi, this is Dr. Perry Carpenter. This video is designed to provide supplemental digital content to the QME Continuing Education Home Study Program, the non-physiologic exam. And in that program, that's a 3-hour continuing education program, we go into extensive detail regarding the non-physiologic exam. And this video demonstrates some of the procedures and some of the non-physiologic examination maneuvers that are discussed in that 3-hour home study program. And I'd like to go over a few of those maneuvers here with you today. I have maneuvers broken down into 3 basic categories, and we're just going to go through quick demonstrations so you get the basic idea of the significance of these maneuvers and how they contribute to your findings and how they contribute to the preparation of your QME reports. So we have these non-physiologic examination maneuvers broken down into 3 basic categories. Number 1 category, the first category, is inconsistent findings. Findings on physical examination maneuvers that would be otherwise inconsistent with subjective descriptions and historic descriptions of both the injury and the examinee's pain. Category number 2 are simulation maneuvers. In other words, physical examination maneuvers that actually should not reproduce pain, but which the examinee reports that there is a reproduction of pain. And I'll go into several simulation maneuvers with you. And then category number 3 are the distraction maneuvers. And I'll explain more about those when we get to those. So to begin, I'd like to go over some of the inconsistent physical examination maneuvers that may be inconsistent with the historic facts of the injury and the treatment history, for example, and also physical exam findings that may be inconsistent with the examinee's reports of pain and the distributions of pain. And some of these inconsistencies will become clearer to you as we go through these maneuvers. So the first one I'd like to share with you is what's called the 90-90 maneuver and its relationship to Miner's sign. So imagine that you are sitting in your interview in the face-to-face evaluation with your injured worker and you observe your injured worker to be able to sit comfortably in the examination chair. Now, if you make a note of this sitting posture, you'll notice that the hips and the knees are both in roughly 90 degrees of flexion. Correct? And what's the significance of that? There is no significance of that, except if later on in the examination the examinee demonstrates inability to assume either 90 degrees of hip flexion or 90 degrees of knee flexion. That would be considered an inconsistent examination finding. So during your interview, you're talking and you note that the examinee is sitting comfortably in the 90-90 position. If you then go to physical examination and perhaps your injured worker is lying on the examination table like so, and you're initiating some examination maneuvers, and for example, you flex the hip and knee, approaching the 90-90 degree relationship, and if the injured worker objects and says, oh no, I can't do that, or they provide resistance to your motion to indicate that they're not going to participate in that movement, that would be considered an inconsistent examination finding. That is what we call the 90-90 finding. Another examination inconsistency that you may encounter involves what's called positive minor sign. Now, with a positive minor sign, due to some sort of limitation, generally it's in the lumbar spine, but it could also be due to pathology in the hip or pathology in the knees. The examinee, in an effort to unweight the injured part, again, whether it be lumbar spine, hips, or knees, will use the chair to assist in the descent. In other words, they use the hands to assist or to alleviate the eccentric phase of the contraction of the spine muscles, of the hip extensors, and of the knee extensors. So they'll use the hands to unweight the eccentric portion, and they'll settle down into the chair like so. Similarly, upon rising from the chair, they will use the hands to assist now in the concentric phase of the contraction. And if you've ever had a pain in your lower back, you know that there's inhibition, there's neural inhibition and weakness of the associated muscles. Okay? So the hands allow a boost out of the chair to relieve those painful and inhibited muscles and allow the injured worker to be able to stand up. So a positive minor sign has two components. It has the eccentric assist and it has the concentric assist. Okay? And you've all observed a positive minor sign. Well, a positive minor sign observed on sitting up and out of a chair, or both into a chair and out of the chair, would be inconsistent with a physical exam finding that demonstrates the ability to perform repetitive squat. Repetitive squat. And a repetitive squat is part of the functional maneuvers generally included with lower extremity exam and lumbar spine exam. But injured workers often, they don't make the connection between the similarity of the maneuvers of getting in and out of a chair and being able to perform a repetitive squat maneuver. So if, for example, your injured worker reports that they're unable to perform a repetitive squat maneuver due to pain in the back or what have you, and yet you're able to observe them to sit down comfortably in the chair, well, those are the same maneuvers. So that would be a physical examination finding of inconsistency. And what does that finding mean? What can you conclude from that finding? Well, actually nothing. Nothing. No one physical examination inconsistency really means anything. You have to take this into the overall context of the case, of the mechanism of injury, of the medical treatment to date, the subjective complaints, and all of that information has to be integrated with your physical exam findings, including findings on non-physiologic exam, in order to come up with a final conclusion that is an accurate representation of the injured worker's permanent impairment or their permanent and stationary condition.